Good morning, students. My name is Nageshwar Rao, Associate Professor in the Department of Pharmacology. Today, we'll discuss about anticoagulants. Anticoagulants, these are the medicines or the drugs used to help to prevent the blood clots. Okay, so these anticoagulants are used in patients who are at high risk to develop blood clots. Thereby, it results in various complications like stroke, heart attack, etc. So, hence these anticoagulants are very useful to prevent blood clots. Why anticoagulants are useful? To reduce the coagulability of the blood, to reduce the blood clotting of the blood. Blood clots, these are also known as a thrombus. Thrombus, when inside the blood is clotted, it is known as a thrombus. It is of two types, arterial thrombus and venous thrombus. Arterial thrombus, it is defined as a stickiness, adherence of platelets to the arterial walls. The platelets, when the platelets and the endothelium is in healthy nature, usually platelets do not stick to the endothelium of the blood vessels. Okay, but when there is any damage in the blood vessel, the platelets will stick to the arterial walls. It results in various complications like myocardial infarction, stroke and ischemia. And venous thrombi, it develops in the areas of stagnated blood flow. It develops in areas of stagnated blood flow, means deep vein thrombosis. Those blood vessels which have very less amount of blood supply, it leads to venous thrombosis. It is associated with CHF, congestive heart failure, cancer and surgery. Okay, as we know, thrombus means blood clot. When the thrombus dislodge from the arteries and veins and become embolus, the big clots may break into small pieces. The small pieces may travel along the arteries and veins and may lodge in the smaller arteries and veins. Okay, that smaller blood clot is known as embolus. Embolus. So, when the embolus blocks the smaller artery or smaller vein, what happens? The blood flow to the other area will be completely blocked. Thereby, it leads to necrosis of the cell and the death of the cells. So, this type of things usually happen and may lead to stroke, myocardial infarction, stroke, okay, etc. So, venous thrombi, venous emboli can block the arteries in the lung and pulmonary circulation. Emboli means small blood clot. Venous emboli can block arterioles in the lung and pulmonary circulation. It leads to thromboembolism, blockade of lung and pulmonary circulation by the blood clot. It results in thromboembolism. Now, coming to the classification of anticoagulants, the drugs used to reduce the coagulability of the blood are classified into two categories mainly: drugs used in vivo and drugs used in vitro. In vitro means they are used in the laboratory conditions. In vivo, it will be administered into the body. Okay. In the in vivo anticoagulants, there are again two types: parental anticoagulants and oral anticoagulants. Parental anticoagulants, there are two types: heparins and heparinoids. These are the derivatives of heparins. Heparins again have sub variety of heparins: high molecular weight heparin and low molecular weight heparin. High molecular weight heparin example is unfractionated heparin, and low molecular weight heparin examples is enoxaparin, dalteparin, tinzaparin, riviparin, and danaparnoid. And heparinoid, these are the derivatives of heparins. Examples is heparin sulfate, hirudin, lipirudin, bivalodin, and argatropin. These are the drugs under in vivo category, in vivo anticoagulants, particularly parental anticoagulants. Now let us see oral anticoagulants. Oral anticoagulants, coumarin derivatives. Okay, so as the name indicates, these oral anticoagulants can be taken orally. Parental anticoagulants which can be administered through parental routes. Okay, examples of orally administering anticoagulants are bis-hydroxycoumarin, also known as coumarol, warfarin sodium, and isonocoumarol, ethyl biscoumacetate. Next, Indian dione derivatives, phenandione. Next category of anticoagulants is those are used in vitro, means laboratory conditions. Heparin. See here example heparin. This is the substance which can be used both in vitro and as well as in vivo. Next, sodium citrate. Generally, the sodium citrate is a very common substance used in blood banks to store the blood. After collecting the blood from the person or volunteer, okay, it will be stored in the liquid form with the help of this sodium citrate. So, see, this sodium citrate acts as an anticoagulant, thereby it can prevent the coagulation of blood within the blood packet. Sodium citrate, sodium oxalate, and sodium edetate. This oxalate and edetate usually they are used in laboratory conditions. While we perform the experiments, this oxalate and edetate normally used in laboratory conditions. So this is the classification: in vivo, parental type, and oral type. And in vitro, these are the examples: heparin, sodium citrate, sodium oxalate. Now coming to pharmacology of parental anticoagulants. In the parental anticoagulants, the prototype of anticoagulant is heparin. Let's discuss about pharmacology of heparin. Heparin, it occurs in mast cells. It is present in mast cells. It is the richest source of mast cells are lungs, liver, and intestinal mucosa. In lungs, liver, and intestinal mucosa, there is a vast source of mast cells are there. In the mast cells, the heparin will be present. Okay, the source is mast cells. The commercial heparin can be obtained from porcine intestinal mucosa and bovine lungs. Commercially, the heparin can be obtained from porcine and bovine type. A mixture of straight chain anionic glycosaminoglycan with a wide range of molecular weight. Okay, heparin is a chemically it is a mixture of straight chain anionic glycosaminoglycan with a wide range of molecular weight. It is strongly acidic in nature because of the presence of sulfate groups in the heparin and carboxylic acid groups. Coming to the pharmacokinetics, ADME of heparin. Heparin is a highly charged molecule, so thus crosses the cell membranes very poorly, hence it is given parenterally. Because of the charge, it can permeate the various membranes very poorly. So it can't be administered by oral route. It can be administered by parenteral route only. Generally, the low dose can be administered through subcutaneous route. High dose can be administered either subcutaneous route or IV route, intravenous route. Metabolized in the liver and half-life, it depends on the dose of the heparin. Now coming to the mechanism of action of heparin, before going for the mechanism of action of heparin, let's recall the blood coagulation or blood clotting mechanisms in the body. Okay, blood clotting takes place in two pathways, intrinsic pathway and extrinsic pathway. So this is the pathway of normal blood coagulation, normal blood clotting. After discussing this one, let's go for heparin mechanism of action. Intrinsic and extrinsic. When there is a damage to any blood vessel, immediately factor 12 is activated. First of all, in the blood coagulation, 13 clotting factors are involved. All the clotting factors plays very important role in the coagulation of blood. So initially, when there is a damage of blood vessel, any rupture of blood vessel, the factor 12 is activated. Okay. So 12 is converted to 12A. Here A indicates activated form. Initially, all the clotting factors which are present in the body, they are present in inactivated form. When there is any rupture of blood vessel, the factors will be activated to activated form. So now 12 is converted to 12A. Next, the activated form of factor 12 acts as a coenzyme, so that it will activate another factor. Now 11 will be converted to 11A. Again, this acts as a coenzyme for this reaction. So 6A will act as a coenzyme to convert factor 9 into 9A. Next, again, it acts as a coenzyme, so that factor 10 will be converted into factor 10A. Okay. Up to here, the intrinsic and extrinsic pathways are different. Let's go for extrinsic pathway. Again, when there is any tissue injury, tissue damage, the body releases one factor that is called tissue factor. The tissue factor will releases one protein called thromboplastin. This thromboplastin will convert factor 7 to 7A. Now the factor 7 will be activated to activated factor 7A. In the presence of factors like factor 12A, 11A and kallikrein is a protein. Next, 12A acts as a coenzyme, so that it will convert 10 to 10A. Okay. Finally, both intrinsic and extrinsic pathways will result the common activated factor is 10A. This is the factor 10A. Up to here, both intrinsic and extrinsic pathways are different. Once factor 10A is obtained, now both intrinsic and extrinsic pathways are common. This pathway we will call it as a common pathway. Next, 10A acts as a cofactor so that it converts prothrombin to thrombin. Again, thrombin acts as a cofactor for converting fibrinogen to fibrinogen insoluble. Finally, fibrin insoluble molecules become stabilized. That we will call it as a blood clot. Okay. So generally, blood is a fluid connective tissue. When there is clotting takes place in the blood, it becomes solidified with the formation of fibrin threads. Okay. So fibrinogen will be converted to fibrin. Initially it is insoluble. Later on the blood becomes solidified, stabilized blood clots. So this is the normal pathway of blood coagulation. Let's go for our drug pharmacology mechanism, heparin mechanism of action. When there is no heparin, the active clotting factors converted to inactive clotting factors in the presence of antithrombin 3. In our body, by default, one protective mechanism is there. When there is any clotting factors are activated, the clotting factors get converted into neutralized form, inactivated form in the presence of antithrombin 3. Antithrombin 3. Okay. This is the normal process when heparin is not present. When heparin is administered to the body, heparin, what it will do? Heparin, it will binds with the antithrombin 3. So it will form complex heparin plus antithrombin 3, 83. This complex fastly convert active clotting factors to inactive clotting factors. Okay, the activated clotting factors get converted back to inactivated form of clotting factors, so that coagulation will be prevented. Okay, in our body all the clotting factors are there, but they are present in the inactivated form. When there is any activation, it is a series of cascade of reactions. If one factor is activated, it activates other factor. That activated factor activates another factor. Like this is a series of cascade reactions. So that we need to inhibit the activation or bringing back to the activation of activated clotting factor to inactivated clotting factor. So heparin, by combining with the antithrombin 3, it will neutralize this complex will neutralizes the already activated clotting factors to inactivated form. So this is the pictorial representation of heparin mechanism. So antithrombin 3, when the heparin binds with the antithrombin 3, the clotting factors get converted to the inactivated form. Without presence of heparin, antithrombin will bring the activated form of clotting factors to the inactivated form, but it is a slow reaction. See here, it is a slow one. When heparin is added to the antithrombin 3, this reaction will be very fast, so that the activated form of clotting factors get converted into inactivated clotting factors. Now you can better understand normal pathway I explained in the previous slide. intrinsic pathway and extrinsic pathway. Now mechanism of action of heparin. Intrinsic and extrinsic, we have seen different clotting factors, activated forms of the coagulation factors. Okay, normally 12 will be converted to 12A, 11 will be converted to 11A, 9 will be converted to 9A, 10 will be converted to 10A, like that. So these are called activated forms, activated clotting factors. Heparin, when it is administered, it will form complex with the antithrombin 3 initially. It will neutralizes the already activated clotting factors, so that we can prevent coagulation of blood in the body. Okay, as we know, even if one factor is missed, the coagulation will not proceed further, because this is a series of cascade reactions. Now let us see the differences between various heparins, low molecular weight heparins and high molecular weight heparins. These are the characteristics. Molecular weight, here high molecular weight heparins, the molecular weight is very high, around 30,000 daltons, and low molecular weight heparins, molecular weight is very low, around 5,000 daltons. Next, metabolism, biotransformation. In high molecular weight heparins it is low, in low molecular weight heparins it is high. Half-life, shorter, it depends on the dose. In low molecular weight heparins it is longer. Mechanism of action, high molecular weight heparins inactivate both factor 2A and 10A. It will inactivate, it will neutralize the factor 10A and 2A. But in low molecular weight heparins, it can inactivate only 10A. Anticoagulant effect, here it is more, here it is less. Why? Because here see, high molecular weight heparins, it will inactivate two clotting factors, 2A and 10A. But in the low molecular weight heparins, it can inactivate only factor 10A. So low molecular weight heparins may produce less therapeutic effect compared to the high molecular weight heparins. Monitoring is required for high molecular weight heparins by thromboplastin test. It can be given once or twice daily without monitoring, but repair special assay is necessary. Adverse effects, not that much serious reactions, but here there is a chance of thrombocytopenia and long-term osteoporosis. Thrombocytopenia, decreased count of platelets, and osteoporosis means fragility of bones. Excretion, it cleared by the reticuloendothelial system. It can be cleared unchanged by kidneys. Reversal, the high molecular weight heparins, the action can be antagonized, can be reversed by administration of protamine sulfate. It is an antidote. The persons who are risk of high dose of administration of heparins can be managed with administration of antagonist protamine sulfate. It is an antagonist of heparin sulfate. It is not fully reversed by protamine. Coming to the cost, it is not expensive, but it is very expensive. Dose response, it is less predictable. Here it is more predictable. Uses, more effective in orthopedic surgeries, pulmonary embolism, unstable angina. Advantage of low molecular weight heparins than unfractionated heparins, means high molecular weight heparins. Low molecular weight heparins, they better absorbed subcutaneous route. 70 to 90% is absorbed on subcutaneous injection compared to unfractionated heparins, means high molecular weight heparins. Through subcutaneous route only 10 to 20% is absorbed, but here 70 to 90%. Longer and more consistent half-life. Once daily subcutaneous administration is enough. Since a prothrombin or clotting times are not prolonged, so lab monitoring is not that much important. Lower incidence of hemorrhagic complications, and it is appeared to have lesser antiplatelet action, so less interference with the hemostasis. Finally, uses of heparin in general. The first use is in the treatment and prevention of deep vein thrombosis, stagnated blood flow. This deep vein thrombosis usually seen, or stagnated blood flow is seen in patients who are bedridden, those who are immobilized. Bedridden people, old people, and post-operative after the operations, and post-stroke complications, leg fractures, and elective surgeries. So in all the cases, we can see deep vein thrombosis. This heparin can be used to prevent deep vein thrombosis in the following patients. Next, uses ischemic heart disease, unstable angina after myocardial infarction and after angioplasty or stent replacement. Next, used in the treatment of atrial fibrillation and rheumatic heart disease. Warfarin, heparin, and low dose aspirin usually decreases the stroke. Next is cerebrovascular disease, useful to prevent the cerebral emboli. Next, vascular surgery, prosthetic valve and retinal vessel thrombosis, extracorporeal circulation, and hemodialysis, thereby to can prevent thromboembolism. Next, defibrillation syndrome or DIC. It can be used to prevent abruptio placenta, malignancies, infections, and increased consumption of clotting factors. Next, coming to the side effects of heparin, adverse effects. The main problem with heparin is bleeding, hemorrhage. If the dose of the drug is increased, it may lead to prolonged bleeding. Next type of side effect is allergy and anaphylaxis. Since the source of heparin is porcine or bovine, so due to the variations of the animal, it may lead to the human beings may produces hypersensitive reactions, allergic reactions. It is also most common. And increased hair loss, alopecia, and long-term osteoporosis. Long-term use of heparins may lead to osteoporosis, means fragile nature of the bones. It may result in spontaneous fractures. Next side effect is thrombocytopenia, decrease the count of platelets, thrombocytes. Okay, heparin induces thrombocytopenia. So once thrombocytopenia is determined, heparin must be stopped, because this is one of the side effect which is caused by heparin. Once it is found, please stop heparin. direct thrombin inhibitor should be given. Platelets must not be given because they will react with antibody already being produced against them. They will be causing high chance of thrombosis. Heparin in the pregnancy. Heparin do not cross the placenta. It must be used instead of warfarin in case of requiring anticoagulant therapy in pregnancy. Okay, in the pregnancy cases, the heparin can be used very safely because it cannot cross the placenta, so heparin won't go to the fetus body, so there is no problem with heparin. Whereas warfarin, it can cross the placenta. Warfarin crosses the placenta and induces the change in the fetus to produce fetal warfarin syndrome. It is not at all advised. Contraindications. In some particular complications, some particular conditions or patients, the heparin should not be administered. The contraindications are hypersensitivity. As we discussed, it is obtained from the porcine and bovine. So, due to the source, some patients may experience hypersensitivity or allergic reactions. So, this is the persons who are allergic to porcine or bovine insulin, etc., it can't be given. Next, bleeding disorders like hemophilia, and thrombocytopenia, intracranial hemorrhage. Within the brain there is a leakage of blood, gastrointestinal ulcerations, threatened abortion, and advanced renal or hepatic disease. Next, antidote. The persons who are in high risk of high dose of heparin, those patients can be managed with the administration of heparin antagonist. The drug is known as protamine sulfate. It is a highly basic peptide that combines with the heparin as an ion pair to form a stable complex. Okay, heparin is a acidic in nature and this protamine sulfate is a basic in nature. So that this protamine sulfate forms complex with the heparin. That formed complex is devoid of any anticoagulant properties. So, in the hemorrhage conditions, it can be reversed. The hemorrhage can be reversed by the administration of protamine sulfate. Usually, it is titrated so that 1 mg of protamine sulfate is administered for every 100 units of heparin. Thank you, students. In this class, we discussed about anticoagulants. What are anticoagulants? Different categories of anticoagulants, and the prototype parental anticoagulant heparin pharmacology we discuss. In the next class, let us see oral anticoagulants. Thank you all.